Good evening. Thank you all for coming. This is a celebration of many inspirational figures and many wonderful teams that I work with and continue to work with at King's Health Partners. So lovely to see you all. Let me start the story by bringing in some intrigue. What does a chili, a cactus, a clam, a sausage, and an orange have to do with overactive bladders? Some of you know this, but I just want you to think about these various things. One word of gentle advice. If you're planning to be on MasterChef, then please do not mix up these ingredients because you're sure to lose on the first round. So please don't do that, but think about what these ingredients might have to do with an overactive bladder. Now, I am based at King's Health Partners, the largest academic health sciences center in the United Kingdom. We are south of the River Thames. So many lovely people, a university in the middle, 4 hospitals. It's absolutely fantastic to be part of such a great team. I'm grateful to the Royal College of Surgeons. Professor Gibson, thank you very much. All I wanted to say about King James IV was, apart from killing people and fighting as he did in those days, he had a keen interest in surgery and dentistry. And guess what? He used to take out the teeth of his subjects and pay them for it. So I would say this was a first example of a learning curve. Yeah? So try it on your subject. The subject thinks the king is not only removing my tooth, but also paying me for it. How wonderful. But such a curious practice. These days I don't think I'm going to pay anyone to have their prostates removed. But then this amazing theater, a unique place, is unique because of Michael Faraday. And here is the Faraday chair, built by Twining. This is in the members' library of the Athenaeum in Pall Mall, just around the corner. And the chair actually can be changed in various positions. You can't sit on it anymore. And this is one of the descriptions of the chair from the Athenaeum collection by Richard Walker and Hugh Tate. And there are so many dreadful, dreadful things that have happened during the pandemic, but this was one of the good things that happened. The book came from the Athenaeum. And the last line of it is, Michael Faraday died in this chair, August 25th, 1867. Now, this is a public lecture, so I'm going to make things very, very simple. We all have 2 kidneys on the sides. They make urine. They come down 2 tubes called the ureters, and then they are gathered in the bladder. Yes? On the left, you see the anatomy of a female, where the water pipe coming out of the bladder is rather short. On the right side, you see the same in a man, where just under the bladder sits this prostate gland, and therefore the urethra is longer. And what happens in 50-year-old plus men, in half of such men, the prostate starts enlarging and starts causing problems. There are some 50-year-olds in the audience here. Thank you. That's very, very kind. You must not remind anyone of how old I am. But let me explain what happens to the bladder in real life by this little demonstration. So imagine that is the bladder, okay? It's like a balloon. Yes, it sits here. Yeah. And 95% of the time, this balloon is just sitting here, gathering urine. Okay, 95% of the time. is just doing nothing, gathering urine. As you sit there, that's exactly what's happening. And that is the urethra. About 6 or 7 times during the day in a normal human being, the bladder will start relaxing because the bladder, the full bladder will start sending signals to the brain through the spinal cord. It's not just sitting there, it's connected by nerves. And about 6, 7 times a day, a little bit of urine will come out. Okay, completely under your control. You can hold on to your urine, and when you feel the need for it, the urine will come out. Okay? Maybe none at night or once or twice at night, but see, and then the bladder will empty itself completely. Just like that balloon. So you may be wondering what happens in the overactive bladder. Clearly, the patient goes to pee more than 7 times a day, multiple times, has great urgency. Yeah? Key in the lock, leaks all over the place. And in the older man, waking up many times at night. And there are 3 common causes for it. There are many, but I want you to remember 3 of them. The first is called idiopathic, so no one knows what happens, but the bladder is overactive. So it's just contracting at the wrong times. The other is where there is a problem with the nerves. I've just described to you, sitting there, so the nerves are affected, and that's called neurogenic. And the third, in a man, is where the prostate enlarges. And you see on the right side diagram, the bladder has to start squeezing against this enlarged prostate like a little child, trying to pee itself. And that is what makes the man get up and go multiple times. So those are the 3 causes of an overactive bladder. And guess what? Urinary incontinence today is more common than diabetes and heart disease combined. An overactive bladder is one of the common causes of it. 30 million patients in the United States, 8 million in the UK, 200 million worldwide. So this is a serious health problem. And yet you wonder why it doesn't receive much funding, because no one's willing to talk about it. People suffer the embarrassment in silence. And I hope after today you'll realize that we can do a lot about it. I learned about the overactive bladder when in 1994 I attended the Mecca, the temple, the church of the nervous system, the National Hospital in Queen Square. You see, the old building is the National, and beside it, the white building, the modern building, is the Institute of Urology. So in the National, the patients are seen, and the science happens in the Institute of Urology. So let me take you through this. This is very interesting, so let me take you through this. It's complex, but you'll like it. This is the bladder, okay? This is the urethra here. That is the sphincter muscle. As I said, it's not just sitting there. It's connected to these various nerves. So this is the brain. This is the spinal cord. We all have it. Otherwise, we wouldn't be walking around. The main nerve here, don't worry about these complex names, it's called parasympathetic. There is another set of nerves which is higher up, which are called hypogastric or sympathetic. So one is para, the other is sympathetic. When the bladder fills up, signals go up, and when you are in a convenient place, the signals come down and the bladder contracts. So in an overactive bladder, it makes sense that you block these nerves, so you can block this here. These tablets are called anticholinergics, and then you can put a signal along this nerve, which is called sympathetic, by actually augmenting that signal. And that is a new kind of tablet called mirabegron or vibegron. Now, this becomes very interesting as well. Look, this is called the pontine micturition center. Forget the name, this is the pons. And there are other various signaling areas in the brain that you can see. This is called the periaqueductal gray, which sits above the pontine center. And these are functional MRI scans, exquisite detail of what happens when you're trying to pee, or when you're just sitting there like you are now, trying to hold on to your urine. You don't even have to work to do it. Unless, of course, you have an overactive bladder, in which case you have to rush out. Now, I want you to remember this by a Hollywood movie. Yeah? So, the Pontine Micturition Center was discovered by a chap called Barrington. I'm told in the 20s he was a magnificent scientist, but a very poor surgeon. So his students, just like many students I see, have said, Prof, just go and do the science, and we will look after the patient. This is true. And he had a big nose, so he was called Snocker Barrington. And he made this fundamental discovery of this thing being, the center being in the pons. The pons is just here. So switch forward in the 80s to Hollywood, to a movie called Lassiter. Tom Selleck was in it. And what happened in that movie was two spies from two different nations are in close embrace, except the man doesn't know that the woman who's embracing him is a spy. So what she does is take out her hairpin and stabs him right here from the back. This is the only part of the body where 1 ml of blood will cause death, because that's where the respiration center is. We are breathing, living because of that. So 1 ml of blood, she knew it, she passed a needle, and the respiration center just sits beside that Barrington's nucleus. So what the movie doesn't tell you is, he of course dies, but he also wets himself. Okay? So that's what happens. I don't think you'll ever forget that after that story. So the other thing I learned at the National Hospital in Queen Square, where I met a famous lady called Professor Fowler, who designed and developed the first such department in the world called Urology, which means you are dealing with the urinary problems of patients who have neurological disease, is quite simply this. If you see, the nerves to the bladder are coming from here, yeah? Lower part of the spinal cord, but the nerves to the legs are just above. Yeah? So look, your legs are below the bladder, but the nerves are exactly the opposite. So while building us, nature got the wiring wrong, I say. But it also means that if you have a problem with the nerve circuit here, say for example if there's a spinal cord injury or you have multiple sclerosis, then your legs will be affected and so will your bladder. So you walk fine, but your bladder will also become overactive. Okay? Clear thus far. This is a very important diagram ascribed to Professor Chet Detroit. Okay? Again, let me take you through this because it is complex, but my job is to make it simple. So this is the bladder. These are the nerves which take the signal up to that center of Barrington, remember Hollywood, and then the signals come down and make the bladder contract. In health, these are called A delta fibers. Okay? If you have a spinal cord injury or multiple sclerosis, this signal is by C fibers or C afferents. Okay? I want you to remember this C afferents. These nerves are exquisitely sensitive to chilies, and chilies contain capsaicin. So that is the first part of your riddle. Now, chilies were not discovered in India. When I became Professor Fowler's research fellow 25 plus years ago, my colleagues used to call me Mr. Chili. One, I was from India, so the mistaken thinking was he loves chilies, that's why he does the job. And there was the second mistake, which was that he's grinding these chilies in mortar and pestle in Professor Fowler's lab and giving it to the patient. Nothing could be further from the truth. Professor Fowler in 1992 had already published that a semi-synthetic solution of capsaicin, the active ingredient of chilies, at a dose of 1 or 2 millimoles per liter, dissolved in alcohol and given with a catheter into the bladder, will change how these C fibers behave, just like we showed in Degroot's model. And therefore, this then became a treatment for overactive bladders in those who had a nerve damage. There is another important thing which happened at this time. This was described as the TRP receptor. Don't worry about what TRP is. It stands for transient receptor potential, but just remember the name TRP receptor. It becomes interesting towards the end because we flash back 20 years later, and this receptor again becomes important. I studied the history of chilies with Dominic Vuaste in the Wellcome Institute. This is the Wellcome Library. Spent many hours looking for this. And Dominic was a historian par excellence. And I realized that chilies were from Mexico and were taken to India by travelers. So what happened is, on the left, you have Christopher Columbus. In fact, the first description of chilies comes from his physician on his ship called Chanca. And then on the right, you have Vasco da Gama. So Columbus saw Queen Isabella, went all the way to Mexico and the Americas, brought chilies back, and Vasco da Gama then takes these from Portugal and lands in southwestern India. So that's how it got there. So what's part of Indian cooking and the national food of this beautiful island is actually not Indian, it's Mexican. Now, chilies, the strength of chilies are measured in Scovilles. So here is something I got from my local supermarket. I'd like to ask you what you think. So let's get this up, please. Yeah. Okay. So here is the biggest one that I could find. You can all see it, can't you? The biggest chili. And here is a tiny little one, okay? Anyone from the audience tell me which is the chili? Anyone volunteers want to come and bite into these? Any takers? What do you think? Is it the fat one which has the greater Scovilles or the thin little innocuous?
This one.
The little one? The little one. You're right. The fat one has 300 Scovilles, okay? The green one has 300,000 Scovilles, okay? And capsaicin, as in the solution that Professor Fowler was giving, has the Scovilles of Tabasco sauce. Yeah? So that's where it is. So let's go back to the slides, please. So one of the interesting aspects of this was translational science. So we were setting about trying to see how this solution of capsaicin could be helping these patients. So I started taking these little biopsies from the bladder. So if you pee through the water pipe, you can also get in through the water pipe. And with a fine biopsy faucet, I started taking these biopsies. And I can tell you, you can barely see them. They're like a pinhead, 1 millimeter tube. But we had this amazing man called Andrew Beckett who could freeze these biopsies, put them in various solutions, and then cut these biopsies. Can you imagine something like this being cut on a cryostat? Unbelievable. But Andrew Beckett could do it. He was in that Institute of Neurology I showed you. He was in the science part. So I used to get him engaged. He'd cut this. I tried cutting them. Impossible. I mean, this needs years of practice. And then I started looking at these with Dr. Crow from UCL, University College London. And this is the first such biopsy we took. You can see in the biopsy certain things. I can point them out to you. So this actually changed the way we started looking at these bladders. So the bladder has a lining which is impermeable, yeah? And then there are various layers to it. This is magnified many times. This layer is called the lamina propria. And underneath it are these fine, tiny nerves, which are those nerve fibers that we are interested in. And this is the detrusor muscle, which is present in about 50% of these biopsies because they are so tiny. They are taken under local anesthetic. So this is what happens when you put a solution of capsaicin. I want you to look at the middle frame. On top is an overactive bladder. When you give it a solution of capsaicin, you see this intense redness. And then 6 weeks later, when you look in, all the redness has settled down. On the right, you see what happens to these overactive bladders. Those pink diagrams, those pink structures in a blue background, this is an image analysis, are these overactive bladder nerves. You put capsaicin, they disappear. And then, if you look again a few weeks or months later, they will return. So you can give them another solution of capsaicin. On the left, you see that there is no lasting damage, because the clever amongst you will say this must be shrinking the bladder. We have looked at these bladders for a number of years, and there is no lasting damage. One of the problems with this was extreme pain. And the late Robert L. Stephen, who I must mention here, an anesthetist, an Australian anesthetist, urged us to anesthetize the bladder by passing a solution of local anesthetic and diffusing it into the bladder by passing a small amount of electricity. This was called electromotive drug administration. The reason I mentioned Robert Stephen is not just because he was a genius at anesthetizing these bladders and other things, but also because of a sad tale. He contacted me literally a few days before he was passing away from bowel cancer. So we lost a good friend there. So this is where we are before we go on to Botox. So if you have an overactive bladder, the majority of patients who go to their GPs, you're either given these anticholinergic tablets or the beta agonists, which I talked to you about, the two kinds of pills I mentioned right at the beginning. If those don't work, then we could give semi-synthetic capsaicin. Unfortunately, never received a license for use in humans, so never took off. And then comes this cactus. Let's have the overhead again, please. So there you see this tiny innocuous cactus, the second part of my riddle to you. The cactus is called Euphobium resinifera, and it contains resinifera toxin, which is 1,000 times more potent than capsaicin. Okay, 16 billion scovilles, mind-blowing. So a company said, okay, let's go back, please. A company said, look, we are going to market this. We're going to market this, and we started trials. And halfway through, we realized that nothing was happening to these patients, except in Portugal. They said, are they receiving some special Portuguese resinifera toxin? Couldn't figure out. No one is responding. What happened was, lo and behold, the only place in Portugal which was part of this trial was receiving the solution of resinifera toxin in glass bottles, and every other center was receiving it in plastic. And resinifera toxin sticks to the plastic. We didn't know that. So we were essentially giving saline to these patients, a complete waste of time. The trial folded, as did the company. Gone, just like that. Today, if the patient doesn't respond, we can stimulate the nerves by putting an implant in the back. And I tell you what, when I was training 25 years ago, the other thing that happened was a clamp cystoplasty. Let's have the next overhead, please. So here's a clamp. You can see that. Imagine this to be the bladder, and we open it up like that. Right? And then into that opening, we put a piece of bowel to enlarge the bladder and dampen the contractions, the overactive contractions. So that is what the clamp has to do with an overactive bladder. And this was popularized by, can we get back to the slides, please? This was popularized by Jim Bramble, who was the president of the British Association of Urological Surgeons. And this is the diagram of the bladder being opened up like this and a piece of bowel going on top, the clamp ileocystoplasty. Major operation, cut from here to there. You can now do it keyhole, you can do it with a robot, but we thought that we had to have something which was minimally invasive. the question mark in the previous slide that I showed you. And that is where botulinum toxin comes in and completely changes the game. By now I had left Queen's Square, only to return in 2002. I was also working at Guy's as a consultant, and Professor Fowler and I decided that I would spend some time again in Queen's Square. So entry 1, exit, this is entry 2. Gets even better. So botulinum toxin was brought about and popularized from rancid sausages. So in the middle, you see this Clostridium botulinum. I don't think you need me to project this. These are Richmond sausages. I can tell you I bought them this afternoon on my way here. Because if I brought in rancid sausages, which is what contains the toxin, the most poisonous substance known to man, none of you would be sitting here and I would be immediately ejected. So I smuggled this in, but I can tell you this is absolutely fresh. So after this we're going to have a fry-up. Okay? So that's where the final part of the puzzle, bar 1, comes in. So it comes from rancid sausages. Please don't eat them. It consists of 2 chains, a heavy chain on the left and a light chain on the right, and in between are 2 linking substances called disulfide bonds. The 2 S's you see in the middle are the disulfide bonds. Okay, this is a big molecule. It's about 150 kilodalton in size, so it's very difficult for this to be put as a solution into the bladder like capsaicin or resin ferretoxin, because it's just not going to go through the bladder into the nerves and the muscle wall. It just won't go there. You may wonder, with such a poisonous substance, surely someone thought that this should be used for bioterrorism. Yes, they did. And during one of the world wars, the thought process was, well, we're going to get it and we're going to slip it into the neighboring countries' warriors' drinks. They're going to drink it, and most of them will be paralyzed and dead. So someone clever thought, we must do some experiments first before we do something so daring. So they fed it to this poor mule. In fact, they fed it to quite a few mules. And the mule just went, and nothing happened. The experiments failed. The mule is one of few animals which is completely resistant to botulinum toxin. So it was never used for bioterrorism, not that we know of, and thank God for that. There are a number of botulinum toxins in the market. The one which is licensed is called Botox. It's produced by Allergan. The others are Xeomin, Dysport, and a botulinum toxin called Myoblok. Notice they are all botulinum toxin type A. It goes from type A to type G. B also works. Type A works the best. B is not used clinically despite a trial because the lasting effect is only for 6 weeks. It's been used for a whole load of different things. First, in strabismus, but you will see right down that the list is neurogenic detrusor overactivity and idiopathic detrusor overactivity. Okay, multiple different uses. So there you are. The original description was not by us. This was first described in patients who are paraplegic, i.e. They have a spinal cord injury, and this was British Schulz from Switzerland, who started using a rigid telescope and injected the bladder at 20 or 30 points with 300 units of botulinum toxin type A. This is the first description in the Journal of Urology. Then she did a trial of this toxin, and you will see on the x-axis are the weeks, week 2, 6, 12, 18, and 24, goes all the way. And on the y-axis, the higher the value, the better the urgency leakage. So the better the lock and key, where you go in, you can't find your key at the door and you leave. So the higher the value, the better is the performance. So in blue, you have 300 units of the toxin, 30 injections. In red, you have 200 units. And finally, in yellow, you have placebo, saline. And you can see, it is obvious to anybody, that the botulinum toxin A or Botox is better than placebo. And then comes this method of injecting it. I didn't name it, the person who did is sitting here. And in fact, one morning he says to me, you have contributed largely to the popularization of the injection, so we are going to name this after you. I said, let me sleep about it overnight before you name anything. So next morning I said to him, look, I've thought about it. I do not want you to name anything after me, and certainly remove my name from the paper. But he went ahead anyway, and this is what I'm going to describe to you. Why the oranges is because for the first time we had to figure out how under local anesthetic, unlike the Swiss, could we go inside the bladder without putting the patient to sleep, getting them into hospital, just in an office in a small lab. Can we go in with a flexible telescope under local anesthetic and with the ultra-fine needle achieve the same, i.e. inject the bladder and the patient goes off? So I thought first that this was going to be very tricky because everything had to be ultra-fine. This is a weight patient. So we started, Matthew Harper, who was the first author on the paper, and I, to try and practice this on oranges. And this is where the orange comes in, underwater. So I've got an orange here, and I'm going to bring Nawal Khan, who is an aspiring surgeon and daughter of a famous urologist, down here. Come on down here, Nawal. Let's see how good you are as a surgeon. Nawal, here is that needle, yeah? Okay? Can you see this needle? So I want you to catch hold of this and take that orange there. Yeah? So hold the needle like this, please, and see if you can pierce the orange. With difficulty, yeah? So this is because if you actually see the needle, let's go to the overhead projector, please. This is fine, yeah? See that needle? You can barely see it. It's 27 gauge. Yeah? So we realize that we can't pierce the peel of orange, which feels like the wall of a bladder. So now I'll come on here again. So we decided we needed a sheath. Why don't you start feeding this into the sheath? Yeah. So we are stabilizing the needle with a sheath, okay? And the sheath will lock the needle in. So come this way, please. So again, an overhead, please. Why don't you lock it in? So you see there is the needle, it just juts out, yeah? Okay? And then the needle has a very fine inner sheath which we remove like that, and we attach this to this, which is the toxin, yeah? And then Nawal is going to pass it through this. Take the needle back, quite right, otherwise it's going to destroy the scope. I was just seeing whether you are as sharp as you usually are. She's realized that this is 20,000 pounds of kit, and if you try to pass a needle through it, tomorrow she has to pay out of her salary. So she tells me, please withdraw the needle. Very sharp, thank you very much. Is it going through? It's not going through. Turn it around the other way. Okay, yeah, just take it off. So what then happens is you pass it through there, and if you can see this, it is flexible. So you can bend it in any direction, have the needle come out like that, and then start injecting like so, yeah? So that's what you do, and you inject 1 ml at each side, yeah? So that is what this technique is all about. Round of applause. So this is what it is. This is the bladder. You go in from below and you inject it at 10 or 20 points under local anesthetic. So this is a short video which I'd like you to watch. Can we put the volume on?
Botox is packaged in single-use vials of 100 units of botulinum toxin in a hemagglutinin complex and should be stored at -5 degrees Celsius. Make sure all the necessary equipment and materials are ready before starting the reconstitution procedure and follow a sterile technique during it. The following materials will be needed. The recommended diluent is sterile, non-preserved normal saline. For the introduction of saline and for extraction of reconstituted Botox from the vial, we recommend 10 milliliter Luer syringes and 2.5-inch 21-gauge needles. Alcohol wipes help to maintain sterile technique. Botox is prepared by introducing an exact quantity of normal saline into the vial. 100 units are reconstituted with 10 milliliters of normal saline, resulting in 10 units per milliliter. To reconstitute Botox, first remove the plastic cap from the vial. Then, with a 21-gauge needle on a 10 milliliter syringe, draw up 10 milliliters of saline. Insert the needle bevel side up at a 45-degree angle into the Botox vial. Slowly inject the diluent, allowing the vacuum to draw the plunger down. Discard the vial if the vacuum does not pull the diluent into the vial. Once the saline has been injected into the vial, gently mix by rotating the vial. It is important that you do not shake it, as this could denature the product. Correctly reconstituted Botox should be clear and colorless. Once the vial is prepared, it is good practice to record the date and time of reconstitution on the vial label. For sterility purposes, once opened and reconstituted, Botox should be used within 4 hours. If being stored before use, it should be stored at between 2 and 8 degrees Celsius in a refrigerator. This product is for single use only, and any unused solution should be discarded. To withdraw Botox from the vial, simply tilt the vial and push the needle to the lowest corner. Because the needle has a broad bevel, it should be flush with the corner, allowing you to draw the entire amount into the syringe. The syringe should be held needle up and tapped to allow any trapped air to rise and be pushed out. In addition, if alcohol wipes have been used to clean any of the equipment, the alcohol should be allowed to evaporate completely. Once Botox has been drawn into the syringe and any air expelled, it should be disconnected from the needle. The syringe is now ready for intradetrusor injections. Before the injection procedure takes place, informed consent must be obtained from the patient and a urine dipstick performed to exclude any infection. Prior to being cystoscoped, the patient should receive antibiotic prophylaxis against any urinary tract infection. The injection procedure is carried out using either a flexible or a rigid cystoscope, instruments that will be familiar to you from other urological procedures. For the minimally invasive technique using the flexible cystoscope, local anaesthetic such as lignocaine gel is applied to the urethra. For rigid cystoscopy, regional or general anesthesia may be required. Access to the bladder is via the urethra. Adequate draping and aseptic technique must be used. For the minimally invasive intradetrusor injection of Botox, a superfine 27-gauge single-use 4mm needle is recommended. The needle should be used in conjunction with a flexible reusable sheath into which it locks. The exact number of injections may vary depending on the specific clinical situation. For example, a 200 unit dose in 20 milliliters of saline may be injected as 1 milliliter, 10 units, at each of 20 points, or with a 300 unit dose in 30 milliliters injected into 30 points. For the most effective treatment, the full length of the needle should be buried in the bladder wall during injection. Injection site pain is usually low, although there may be some discomfort due to the unfamiliar situation. If the patient is unable to tolerate the injection, the bladder may be instilled with 40 milliliters of 2% lignocaine for 20 minutes. Inclusion criteria for minimally invasive intradetrusor injection of Botox are: proven overactive bladder, overactive bladder refractory to anticholinergic treatment. Patient is willing and able to perform clean intermittent self-catheterization. Exclusion criteria for the procedure are: urinary tract infection at the time of injection, pregnancy or planning a family, patient is on anticoagulants, e.g. warfarin, bladder malignancy. During the procedure, the bladder should look similar to the example shown here.
You can barely see the needle. It's very, very fine, and you bury the needle right to the base of the sheath. The needle is 4 millimeters in length, just like the outside of an orange. The bladder wall is roughly 4 to 6 millimeters. So you know it's within the bladder wall. So what about the results? Let's look at some results and make them simple. Urgency, the lock and key phenomenon. You wet yourself when you can't get to the door with your shopping. So if you see what happens at baseline, these are people who have severe urgency, and then at various time points. The higher the value on the y-axis, the worse is the urgency, and you can see after Botox injections, the urgency reduces dramatically. And this is also for the second, and in fact you can keep injecting 20 times, the same will happen. But here is the problem. A number of patients in this study, 40%, were unable to empty the bladder. So the bladder had been paralyzed to a point where the bladder was not emptying itself, and you had to put a catheter in, teach the patient to put a catheter in, which is called clean intermittent self-catheterization. So clearly, while it was highly effective, a lot of patients were having to be taught intermittent catheterization. I mean, they refused, they wouldn't have Botox treatment. What we realized subsequently is this was with 300 units. This was not a dosing study. If you reduce the dose to 200 units in those who have nerve problems, the neurogenic bladders, then you reduce that number of patients needing to perform intermittent catheterization. And indeed, the standard dose now for those where the bladder is overactive for no reason, the idiopathic detrusor overactivity, there you inject only 100 units. And that's where this man comes in. He is sitting at the back. Arun is a colleague, was a PhD student at the time, and he performed the first randomized trial in the world comparing Botox versus placebo in precisely this more common patient group, i.e. the people who are just walking around and have an overactive bladder for no reason. Again, the first chart is baseline, and then you see that the size of the bladder, MCC, is maximum cystometric capacity, how much it holds, and this is the size of the bladder, and you see at various time points, 12 weeks, 24 weeks, you have an increase in the size of the bladder. So the bladder is holding more, and the patient is going to pee less. And then there are dosing studies. On the left you have an American study, on the right you have another study from Portugal, a European study, and here you are comparing in green, which is placebo, versus Botox in purple. And here, the more the curve drops down, the better it is for urgency incontinence. So the less you leak, the more the curve drops down, the less you leak, and you can see clearly that Botox is better than placebo. The only thing is, placebo is also effective in over 30% of patients. I wish someone would market placebo, and make a lot of money. A bit like bottled water, you fill it from a tap, somehow manage to seal it and sell it as Highland Spring. I'm not saying that's what Highland Spring is, but I wish someone would market placebo because it's effective in a lot of people. The median duration of effect is about 10 months, which means we roughly inject botulinum toxin once a year. This is the dosing study. Again, this happened in idiopathic diffuse overactivity, and I just want you to focus on this part. This is 94% of patients who are not needing to catheterize and only 6% needing to catheterize. This was called the EMBARK trial, and this really led to the licensing of botulinum toxin by NICE, by the European Urology and the American Urology. And this is from Chris Dawson, who's Arun's PhD student, showing that at each time point you can keep injecting the toxin and the patients will get better. And this is over a long period of time. We have Sachin Marde, my colleague, also in the audience, and Sachin started asking patients, these are called patient-reported measures. And in green you have the patients, light green, who have had Botox over a number of years. In dark green, those who are not having Botox. The higher the value on the y-axis, the better the patient satisfaction. And again, Botox is winning over those who are not having treatment. Now, we were charged with looking at the mechanism of action. How does this work? If we are going to get it licensed, if it's going to be a treatment for the future, we need to know how it works. This is Apostolos Apostolidis, now a urologist in Thessaloniki, who did all this work. He used to have very fast hand. That is a pipette in his hand, but you can barely see the pipette. He's moving it so quickly. And the way it works is you have these vesicles. So the nerves have these little sprouts, and inside the sprouts are these vesicles. This is a nerve ending, and these little vesicles contain a liquid called acetylcholine, a signaling transmitter, and it releases itself into this part, and what Botox does is stops this signaling by breaking these proteins here, one of which is called SNAP25. So the acetylcholine can come in, and that's what happens. So here is a little video again. Can we put the volume up, please?
During normal muscle contraction, acetylcholine is released from synaptic vesicles in the presynaptic motor nerve terminal. The snare complex, involving the proteins syntaxin, VAMP, synaptobrevin, and SNAP25, allows vesicles to fuse with the nerve membrane. Acetylcholine is then released and diffuses across the synaptic cleft before attaching to its receptor on the postsynaptic membrane of the muscle cell to enable contraction. After injection, the fluid environment causes the interactions between the approximately 150 kilodalton core and the accessory proteins to disassociate over time. The binding domain of the Botox core molecule is the C-terminal portion of the heavy chain, which interacts with the receptor complex on the nerve terminal to form a multi-receptor complex. The Botox core molecule enters the nerve cell by the process of receptor-mediated endocytosis. The toxin is now contained in a membranous vesicle inside the nerve cell. The light chain is then released into the neuronal cytoplasm, where it cleaves its snare protein target, SNAP25, to prevent the docking of the synaptic vesicle. Disruption to the snare complex prevents synaptic vesicular fusion and neurotransmitter release. In motor neurons, Botox decreases acetylcholine release to reduce or prevent muscle contraction.
So here is, again, a bladder biopsy like I showed you before, except it is magnified many times. And you see these tiny little nerves, they have the Botox receptor in them, so that's how we can block it. And again, remember back to the capsaicin days, TRP receptors. It can block these receptors by reducing the function of these signaling pathways in the bladder. We have been looking at another molecule called ATP, which is very common. We all in this room have it. And the problem with ATP is, as you don't pee and keep holding on to your urine, the amount of ATP in your urine goes down. So we have been studying what Botox does to ATP, but the problem is it vanishes. And therefore, everything you have with ATP then becomes a problem, and we do not really know whether this is active as far as Botox is concerned. Professor David Langdon was able to magnify these in Queen Square even more. So this is an electron microscopy, and you can see these tiny little vesicles in the bladder. This is just in the nerves. Yeah? They are sitting literally beneath the surface of the bladder. And what happens is you have these multiple different molecules, multiple different signals, which are talking to each other. I would like you to think of them as lock and key mechanisms, and there are countless of these in the human body. And what Botox does is blocks all of them, just like that. The way to remember it is many locks, but one key. So this is the one key which unlocks many different locks. I would never say this in the World Congress of Thieves, of course, because that would be a disaster. But this is the key to many locks. What about the future? Pankaj wanted me to talk about the future. A few years ago, I went to the Swiss Continence Foundation as their editor-in-chief of the British Journal of Urology International, and sadly, Superman had passed away by then, with a dream of nerve regeneration of the spinal cord. And for the first time, we had a description of these amazing antibodies called anti-novo-A, which can actually regenerate the spinal cord in a spinally injured animal. And this is currently undergoing clinical trials. So the future, I think, is very, very bright indeed. I want to acknowledge a number of people. The first is Professor Claire Fowler, who's inspired me on the left, and on the right is Professor Shamim Khan, who is here, an amazing colleague, an absolute guru, who was also part of the Botox trials with Arun at Guy's Hospital. There are a number of people to thank. As I said to you, these are about wonderful teams. This is not about one person. Iqbal Hussain has flown in all the way from the United States. I met him at the American Urological Association less than a week ago, and he said, I'm flying in, not having heard that this was happening. So that's pretty special. Thank you, Paul. But then Jill is here, Jill Lockett from King's Health Partners. Thank you so much for representing my current home. And then, of course, the team at the London Clinic, my science team at Surgical and Interventional Engineering at St. Thomas's, and the wonderful team here, Lisa Derry, Hassan, and Ross at the Royal Institution. These are the funding bodies, mainly the Multiple Medical Research Council, the Multiple Sclerosis Society, which really allowed us to teach this technique to many, many urologists in the UK and all over the world to perform this safely for their patients. And then the Urology Foundation, a charity which really is the key partner in our own Sahai's trial. And finally, I end in this magnificent room, which features on a 20-pound note, as you know, with Michael Faraday in the middle of it. What a privilege to be here, but still trying for who knows what is possible. Thank you so much.
Professor Dasgupta, that was absolutely fantastic, as I'm sure you all agree with me. You've really, I mean, I've learned a lot of things. For example, well, the first thing I learned was that chilies don't come from India, which really broke my heart. But anyway, but you've really helped to demystify quite an important clinical area, and it's often a taboo subject, actually, to talk about incontinence. It can affect people's quality of life. So I congratulate you and your wider team who are here in doing some really fascinating science to try and address that problem. Professor Dasgupta has agreed to take some questions, actually, so if anybody's got any questions in the audience, I'd be very happy to take them.
We've got microphones to you, so if you guys have questions, you can just raise your hands, we'll bring the mic over to you.
I'll start you into silence. Susan has a question.
Thank you very So Botox wears off after 10 months. Do you foresee any way in which Botox could be made permanent?
Yes, we tried this. This is an old story where first Stephen, who I mentioned, said, Prokar, we can try and pass some electricity through it so that it goes deeper into the bladder. This is when he was alive. And he said, I can do some experiments. And the experiments failed because the molecule is too big. Even if you drive electricity through it, it won't go through the lining of the bladder. That's why we have to inject it. The next challenge was, can we make it last longer? So we tried, along with the manufacturers, to try and modify the protein. And again, there were alarm bells, particularly with the thought of terrorist attack. So that fell by the wayside. So as far as I'm aware, there are no other attempts being made to give one injection and it lasts 5 years. Because one, if it becomes permanent, then it's difficult. And two, I think it could be used for the wrong purposes. So we are stuck with what we have. It's the best that we have today, but it is highly effective as it is.
Does it do sitting in the walls of the bladder the same thing that Botox does when people inject it into their faces? Is it a tightening effect?
Exactly right. But it does it better. So the face, the muscles are called skeletal muscles. And there it does what I showed you in the video where these little vesicles are blocked. So the signaling of this chemical does not go into the muscle. So the muscle is paralyzed and you behave like that. Sure? But that lasts every 3 months. So you have to go to Boots or wherever it is, and someone else gives you another jab and look beautiful, etc., etc. I'm sure you don't have that. In the bladder, it lasts nearly a year, and this is because of the signalings that I showed you, the multiple locks and different, the one key. It doesn't just block the muscle, but it also blocks the sensation from the bladder going to the brain and then coming down to the muscle. The muscle in the bladder is different from this muscle. This is called skeletal. That's a smooth muscle, and we also feel that it has this effect on the nerves. Therefore, the effect is exactly the same. It reduces the urgency, it paralyzes or partially paralyzes the bladder muscle, but hey, it lasts longer, good for our patients.
We had one question just here.
Carrying on from the question about the lasting 10 months, but I think you very quickly jumped over, I think you said something like you could do 20 of these, or yes. I mean, how many in a row can you have of these before you can't give them anymore? And if you started off with someone that was in, say, their 20s, if they continue to get them up until their 40s, is there something to stop them getting into their 60s, or do they end up back in the same boat they were in?
This is a great question. The honest answer is we don't know what happens in a 20-year-old and what would happen at 60. What we do know is that over a roughly 20-year period, you can, for those wanting it, you can keep injecting it. There's no long-lasting damage to the muscle or the nerves, they all recover. But we don't know much beyond that. And you can keep injecting it with equal efficacy. There was some worry of forming antibodies, just like antibodies to any other substances. But that seems to be unfounded. There was worry about what happens in those who have had Botox in their wrinkles. Can you inject the bladder? Yes, you can. And the worry about antibodies blocking the effect is largely unfounded.
So can I just have a quick comment on that?
Please.
So in that instance then, because the last bit was talking about, was it harming a nerve or destroying a nerve? So is there an impact long term over that nerve damage, and does that build upon it with each injection?
Not for the time being. So the nerves recover, and they seem to recover well without any lasting damage on the nerves or the muscle or the entire bladder. Otherwise, by now, of course, one, I wouldn't be giving this lecture. I'd be hiding somewhere, and two, I'll be receiving hate mail from patients. So none of that has happened. So it doesn't seem to cause any permanent damage to anything else. Question?
That was a great talk. Thank you very much. The effect that you saw in placebo and injection, do you think that's a central effect, i.e. psychological, or do you think it's a local effect because of the swelling and edema that the injection causes and therefore potentially disrupts the look, at least temporarily, the effect of the neuronal structures in the wall of the bladder?
I suspect it is more a central effect, and what happens to the bladder itself. I mean, if you inject saline into the bladder, what will it do? Nothing. But clearly the patient doesn't know because this is a blinded trial, and there is an effect on the mind. Yeah? And this is true with tablets as well. You pop a tablet, you pop a sugar cube, and in some tablets, nearly half the patients who are having sugar cubes say they're better. So it must be a central effect on the mind. It's the power of suggestion, where the patient doesn't know what they have.
Thank you very much for a very interesting lecture. Just a quick question, was there a difference between the results for men and women and the age groups?
Yeah, so we clearly haven't given it to women of childbearing age or those who want to be pregnant because we just don't know the effect, and that is, as you saw, an absolute contraindication. We've also avoided it in very elderly men because their prostates have become bigger, and therefore if you inject Botox in this man, the bladder is paralyzed to a point where the man will go into complete retention, i.e. they can't pee. So the men need more a chance of having to pass a catheter to empty their bladder than women, because men unfortunately have a prostate and women don't. So age group wise, those are the ages to avoid. Men, be more careful about the need for needing to pass a catheter themselves, maybe once or twice a day to empty their bladder.
Thank you. That was such an enjoyable lecture, Professor. And you covered so many very complicated things and explained them so clearly. I really enjoyed it. And I was particularly interested in that gentleman's question about the long-term follow-up, which of course I was always very anxious to hear. Many congratulations.
Professor, thank you so much. You have graced us all by your presence.
Any questions from the top at all? Standing. I have one question actually, Prof. I mean, you're doing your fantastic journey here, and there's going to be some scientists and young researchers in the audience. Can you talk about some of the challenges that you face on translating from bench to bedside?
Yes.
And how did you overcome those challenges?
Yes, the dark days, yes. Many challenges on the science side and on the clinical side. On the science side, the most frustrating thing was turning up to the lab and finding that these biopsies had bacteria infected. So you turn up, you have done 12 hours of work, you've stained them, you're excited, you go in the next day, let me look at some biopsies under the microscope, and all you find are bacteria, completely dead, and you have to start again. So lab science is like this, it's like a sine curve. You have great days, you have terrible days, you have to pick yourself up again and carry on till you get the answer. So the first thing is don't give up. On the clinical side, I think with the capsaicin trials, one of the reasons why we couldn't really take it to licensing, etc., was because the randomized trials are so difficult. We said, why don't you randomize patients into saline and capsaicin? The problem is the solution has to be prepared inside a fume cupboard. It's so pungent. And therefore, as soon as we were giving it to the patients, we could smell it, and the patient could smell it. Who are you making a fool of? So that was pretty difficult, and we certainly did not manage to do a randomized control trial. The other thing with the Botox story is many patients just drop out, so they just don't turn up. And we know because Sachin Mandya, as I showed you, has been looking after these patients for a long time. And some patients, just as they grow older, say, well, I'm just going to manage with pads. You know? So that's a frustration, because here is a treatment which you can continue having once a year, but many patients just go back to using pads and suffering in silence. So those are the challenges we faced. We sometimes overcame them and sometimes we didn't. But the answer was do not give up, because this is a 25-year-old journey.
Did you ever find out why the mules survived?
I didn't do experiments on mules. I better not talk about animal experiments. In fact, when I was at Queen Square, you really had to do them very, very carefully, because as you know, they are not popular on this island for the right reasons. No, I never experimented on mules, and I suspect if I tried, the mule would have probably kicked me in disgust, saying, go away, etc., etc. So no mule experiments, thank you very much.
Any further questions at all? If not, then I'll invite Professor Gibson to do the final presentation ceremony.
I think you'll all agree tonight we've had a fantastic lecture and exhibition. I had no idea that the wall of the bladder was just quite so complicated, but maybe that's because I'm an orthopedic surgeon and I reckon it's very simple. I do have some interesting questions which you can maybe talk about over dinner. We've always been interested in the sinovertebral nerve, so I'll question you about that. But I think we'll all agree that this has been a super performance, and I'd very much like, on behalf of the college, to present this plaque to Professor Dasgupta. Thank you very much indeed.